right, well, welcome everyone. I apologize here for a little bit of delay in getting started. We were just fixing a technical issue on our side, but we're really happy to have everyone here for the first in the CAPER educational series. So these webinars will be every Thursday night at this time for the next 5 weeks, I guess, including this one. We have a really great lineup for speakers today. I'm kind of pinch hitting here as the moderator. Unfortunately, Dr. Freeman was stuck in travel. Dr. Jay Freeman, who was supposed to moderate tonight and sends his regrets. I'm Melina Bellin from the University of Minnesota. And I'll turn it over to my co-moderator here to introduce himself and our first speaker of the evening.
Yeah. Good evening, I'm Jamal Yazji, joining from University of Illinois at Chicago. I'm happy to moderate this session with Dr. Melina Bellin, and the title of our session is Medical Management of Acute and Chronic Pancreatitis. We will have approximately 20-minute talks, followed by QA and discussion part. If you have any questions, please post these to the chat during the presentation, and we will bring these up during QA session. So I'm honored to introduce our first speaker, Dr. Walter Park. He is an associate professor of medicine at Stanford University. Dr. Park's clinical practice focuses on diagnosis and management of acute pancreatitis, chronic pancreatitis, pancreatic cyst, and the early diagnosis of pancreatic cancer. His research focuses on translational biomarker discovery for chronic pancreatitis and pancreatic cancer. He is a PI for the NCI's Pancreatic Cancer Detection Consortium and also NIDDK, CPDPC, and Type 1D APC. The title of his talk is Medical Management of Acute Pancreatitis.
Well, thank you, Jamal. I guess that's my cue to kind of get going. So first of all, I want to thank all of you for spending a little bit of your evenings with us. As a past president of the Collaborative Alliance for Pancreatic Education and Research, I want to welcome you and also, again, orient you to our organization. And I've been tasked to provide a primer for this, kicking off this Pancreas Academy 2020, discussing the medical management of acute pancreatitis. So these are my disclosures, but all relevant financial relationships have been mitigated and are not relevant to this talk. So I think, as those of you know, acute pancreatitis is common. Perhaps the most common pancreatic disorder that we deal with as physicians, providers who focus on pancreatic disorders, with an incidence of 110 to 140 per 100,000, accounting for over 300,000 ER visits per year. And the admission rates seem to be only climbing over time, with a fairly substantial burden in terms of finances to our healthcare system. Last measured at 2.64 billion in 2014 and rising. The basic take home is this is a fairly prevalent issue, lots of hospitalizations, and for those of us interested in this topic, there are a lot of patients who suffer from this disorder. So I've been tasked with talking about medical management, which specifically doesn't include the word surgical management or procedural management. I'm going to confine my discussion, given that we only have 20 minutes to talk about these aspects. And that is confirming the diagnosis, evaluating for etiology, defining the severity, and providing therapeutic care. So the diagnosis of acute pancreatitis, in an effort to standardize care so that providers are talking the same language when we talk about a patient with acute pancreatitis, is a clinical requirement of 2 out of 3 criteria, typically with abdominal pain consistent with pancreatitis, an elevated lipase or amylase greater than 3 times the upper limit normal, adjusting for the fact that while these are fairly specific markers, there can be false positives or non-pancreatic causes of acute pancreatitis. And finally, if these 2 criteria cannot be met upon clinical evaluation, the use of CT, MRI, or ultrasound imaging showing evidence of inflammation may be indicated to demonstrate and confirm pancreatitis, particularly in sedated patients, or perhaps in patients where beyond pancreatitis, perforation may be suspected, or that there's been a prolonged time of onset such that the lipase and amylase may have normalized given its half-life. In terms of etiologies, once you assume or confirm the diagnosis, then part of the management is to assess for etiologies. Gallstones remains the most common cause of acute pancreatitis, And I put it under the classification of an obstruction mechanism because of the current hypothesis that a gallstone gets stuck in the bile duct and the common channel, leading to an obstruction mechanism, leading to premature trypsin activation of trypsin and pancreatitis. But you can think of other potential obstructive causes, be it strictures or solid or cystic masses. Alcohol-associated pancreatitis is perhaps the second most common, as well as a whole cohort of medications that's been seen in the literature with a subset that seem to demonstrate clear association with pancreatitis. Hypertriglyceridemia is increasingly recognized, and in other parts of the world is a fairly common cause of pancreatitis. Less and less common is ERCP due to the fact that we're limiting our use of such procedures to therapeutic as opposed to diagnostic. Increasing recognition of autoimmune pancreatitis, particularly the type 2 variant, or also known as idiopathic duct-centric pancreatitis, is considered cause infections as well as underlying hereditary mutations that can lead to acute pancreatitis. Once you've confirmed the diagnosis and have a sense of what you might think is the cause of the patient's acute pancreatitis, while the patient is in the emergency room or hospitalized, you may want to then determine the severity of acute pancreatitis, which is defined as mild disease with no evidence of organ failure or local systemic complications, which is the most prevalent form of acute pancreatitis in severity, from representing 80 to 90%. Followed by moderately to severe disease, a range of 10 to 15%, where you may see organ failure, but it's transient and that it resolves within 48 hours. And there may be local systemic complications without organ failure, such as necrosis or peripancreatic necrosis. And finally, there's severe disease, now defined as persistent organ failure of greater than 48 hours. So now that you've made the diagnosis, you've considered the etiologies, you've assessed the severity, now you want to talk about pharmacological management of acute pancreatitis. And this is the big take home, is that we do not have any pharmacological agents as of now for acute pancreatitis. And we hope that will change, but rather but this is actually a list of previously studied, both preclinical and clinically studied agents. So it's not for a lack of trying in the course of the last 3 decades of looking at different types of agents in acute pancreatitis, ranging from anti-secretory agents to protease inhibitors, immunomodulators. In fact, if you look on clinicaltrials.gov, some of these agents are still under active study, including infliximab, as well as a crack channel inhibitor. We know about endomethacin being used in the post-ERCP setting. It has been studied in the all-comer setting without much efficacy. Antioxidants, as well as simvastatin and other types of agents have been studied or are under study. So there is some potential hope, but the current standard of care is such that we do not have any pharmacological agent that we can prescribe or administer when you have a patient with acute pancreatitis. So what is therapeutic care then? Well, it's primarily supportive, and the cornerstones really are fluid resuscitation and nutritional management. Beyond that aspect, there are some considerations for necrosis management, and some brief touch on points regarding the role of ERCP and cholecystectomy that I will touch upon in this brief presentation. So fluid resuscitation, it's been studied somewhat substantially, and the main rationale behind its efficacy is that in pancreatitis, you have significant intravascular depletion from the edema and third spacing, as well as vomiting and loss of intake, as well as ileus, that leads to a relative intravascular depletion that can contribute to multi-organ failure, as well as sepsis physiology. And so the idea being is that we've over time have increasingly recognized the role of fluids as part of therapy. And perhaps we went from one phase of recognizing that we weren't giving patients enough fluids to perhaps being aggressive and perhaps over-resuscitating patients and causing some comorbidities, particularly pulmonary edema, which, as well as in patients who had congestive heart failure, as well as chronic renal insufficiency, to now an idea of goal-directed fluid therapy, essentially starting with some form of a bolus with a fairly aggressive resuscitation rate of 5 to 10 milliliters per kg per hour, but titrated then to when you see a heart rate achieved below 120 or MAPS between 65 and 85 or decent urine output, or hematocrit of 35 to 44%. And much of these recommendations are built on randomized controlled trials, which were done on goal-directed therapy, demonstrating a lower mortality from sepsis. There is a preference of lactated ringers over normal saline. And if you look at the various different guidelines, most of them generally will make note that lactated ringers would be preferred over normal saline, perhaps due to its immunomodulatory effects and a slightly higher pH. In terms of nutrition, the paradigm of management has been evolving such that we are now trying to be more proactive about nutrition, and many of our prior concepts of keeping a patient NPO for fear of exacerbating pancreatitis has essentially been debunked, and we're moving forward with an early oral feeding recommendation, demonstrating as early as admission, so long as the patient's willing to tolerate it. And this has been based on several randomized controlled trials that show no difference in mortality between early versus delayed feeding, and an improvement in a worsening of infection rates in delayed feeding, as well as multi-organ failure. And it's not, and furthermore, not only do we want to start nutrition early, we also don't necessarily need to start with clear liquids. You can even start with a low-fat, soft mechanical diet. And the idea behind driving these improved outcomes is thought that maintaining enteral nutrition will help protect the gut mucosal barrier and reduce bacterial translocation, leading to some of the later sequelae of infected necrosis. Now, if a patient's unable to eat, which is a common occurrence, the thought is to initiate enteral nutrition and definitely over parenteral nutrition. And this has been associated with an improvement and a comparative improvement in a reduction in infection risk as well as an organ failure. And this gets back to perhaps a stimulation of the gut mucosal barrier. And furthermore, the traditional thinking was that enteral nutrition feeding had to be done nasojejunally or beyond or post-pyloric, and that does not appear to be the case. In fact, even a nasogastric tube would perhaps suffice. Now, there could be some theoretical or concerns of aspiration risk, but this did not play out in the studies. But one pearl is to make sure you check for residuals in case a patient may have evidence of ileus. Now, moving beyond those cornerstones of fluid resuscitation and nutrition, we can talk briefly about necrosis, which can happen in moderate to severe acute pancreatitis, of which a subset, about 40 to 7%, can become infected. And in those situations, this is a significant comorbidity and a high risk of mortality. In terms of managing and identifying this, we rely primarily on clinical and imaging and less on the need for an FNA due to false negatives being up to 25%. The general recommendation still is to medically manage this with IV antibiotics to try to minimize drainage or debridement to 4 weeks after the formation of the peripancreatic fluid collection. Patients, as noted before, gallstone pancreatitis or acute biliary pancreatitis is the most common form of pancreatitis. And these patients can often appear ill. They can often have fevers. And the clinical question remains, is there a role for ERCP? And it appears over several different randomized controlled studies that urgent ERCP had no impact on critical outcomes. And the only reason to consider ERCP is in the setting of clinical suspicion of cholangitis. Furthermore, in the realm of acute biliary pancreatitis, I think many of us are familiar with patients who get diagnosed with gallstone pancreatitis, but for some reason or for a variety of reasons don't get their gallbladder removed during the index hospitalization, often having citations of needing the gallbladder to quote, cool off or and have them come back to the general surgery clinic later on. It seems that more and more this is being increasingly recognized as something that should be done at the index hospitalization and before discharge, showing that doing an in-hospital cholecystectomy by one randomized controlled trial had a reduction in mortality as well as gallstone-related complications, as well as readmission for recurrent pancreatitis. And there was no difference in conversion rates between lap to open. And so perhaps the take-home point here is when these patients do exist, to be fairly proactive in getting these patients having their gallbladders removed before discharge. Finally, in alcohol-associated pancreatitis, there have been some studies demonstrating counseling to be beneficial, even if brief and simple, prior to discharge, showing that it may reduce total hospital readmissions and recurrent pancreatitis. And an old study from Nordbeck and colleagues over 10 to 12 years ago showed that with repeated interventions, even with the use of a registered nurse, there was a reduction in recurrent pancreatitis, particularly in the repeated intervention arm. So in summary then, medical management is comprised of a correct diagnosis, identifying the etiology, defining the severity, and providing supportive care. And the cornerstones are targeted fluid resuscitation, early feeding and enteral nutrition, and there's a sore need for pharmacological agents to help disrupt what we understand currently of the inflammatory activity that often leads to a cytokine surge and multi-organ failure. And with that, I'll stop and thank you for your time and attention.
All right, thank you, Walter, for that talk. If anyone has questions, please go ahead and put those in the chat function. And so the first question here is, how do you approach fluid resuscitation in patients who do have heart failure and stage renal disease?
Yeah, so that gets back to the point that we move towards goal-directed fluid therapy. So I would probably start with 5 to 10 milliliters per kg per hour, but knowing about their status, be careful about monitoring and looking for those signs that they are being adequately resuscitated, but also monitoring for the symptoms of pulmonary edema or fluid overload. In some of the more moderate to severe patients, these patients can get quite edematous and anasarchic during the course of their hospitalization. And there comes a time after the first several days where there becomes a discussion of whether diuresis is necessary, whether the fluid is causing intra-abdominal hypertension. In my experience, so long as they're not experiencing signs of pulmonary edema or it's affecting their vital organs, I generally, while I back off from the fluid, I do generally push on, realizing that this is kind of part of the course of care.
Awesome. I think we have a couple more questions. The second one, Dr. Park there, wondering, can you discuss the impact of an acute necrotic fluid collection or inflammatory collection on index admission cholecystectomy?
Yeah, good question. I suppose I'm not familiar with any studies that have looked at that, and I guess that is a unique clinical consideration. I would suppose that so long as the collection is not interfering with the ability to do a laparoscopic cholecystectomy, one should push for index admission cholecystectomy, primarily again because the idea is the gallbladder is the root cause, and the goal of removing it is to prevent future worsening and further progression of such collections in the absence of preventing a future recurrence. I could imagine from a surgical perspective, if your institution does lap transgastric necrosectomies, you could argue from a parsimonious perspective to try to do both at the same time and wait 4 weeks. So that might be perhaps an example of where you might want to wait 4 weeks, but that's beyond the realm of evidence, and that's kind of tailoring it to the patient.
Great. I think the next one here is about pain control, and should we use opioids to control pain to help patients take oral intake in the setting of acute pancreatitis?
Yeah, well, I think opioids is primarily the mainstay of many patients who get hospitalized for acute pancreatitis because of the severity of the pain. And I think it is important to try to make a patient comfortable, but Michelle, as you know, it is a double-edged sword here because these same medications probably delay and exacerbate some of the secondary ileus effects that we see in acute pancreatitis. You know, I think it's an interesting area as to whether, in thinking about this, I think there is an opportunity for more research on this topic. I think it's perhaps just assume that this is how we should do it. And there is a protocol, I think, looking at enhanced recovery protocols like they do in surgery to see if that would lead to better outcomes. And in those protocols, they use less opioids. So that might be one way to get at trying to better understand the impact, negative or positive, of opioid use in the index hospitalization for acute pancreatitis.
have a couple more questions. The next one is about drug-induced acute pancreatitis. Can you name some of the common medications responsible for causing pancreatitis?
Yeah, there are some good, nice papers or review articles that have looked at this to try to kind of hone in on those that have some good evidence where they've retrialed medication use exposure leading to recurrent pancreatitis. Some of the ones that we think about are IBD medications like or immune modulators like azathioprine and mesalamine. Even common medications like Lasix has in some individuals has demonstrated evidence for pancreatitis as well. But I would probably cite, those are some of the things that I've come across, and I would encourage you to look at some of those review articles.
Great. The next question here is, do you have some tips to tell the difference in someone with acute pancreatitis that has fever, leukocytosis? Is this because of the pancreatitis SIRS, or is it an infection, either necrosis or a different infection?
Yeah, very good question, because it's so easy for the guidelines to kind of pound and say, do not give antibiotic prophylaxis. It's not indicated. It's probably, and it's very easy to say, but when you're taking care of the patient who is in SIRS, and you're following SIRS protocols or sepsis protocols, you are, culturing them up and empirically starting them on antibiotics. I think, from that perspective, it's okay to consider initial antibiotic usage when the situation's not clear. It's uncommon when someone is having pancreatitis to also be concurrently infected in the first week of pancreatitis. Oftentimes that surge is related to just the inflammatory surge, but it's not unreasonable to go through the sepsis bundle and to go ahead and get blood cultures, check accessory urine, and to check for those things. And if those things all seem negative and all you really have is pancreatitis, then you're most likely dealing with an inflammatory surge, and then you can probably just stop the antibiotic.
Actually, maybe I can take the last question on to that one before we circle back up to the second to last, because I think it's kind of related here. And it is, what is your threshold for imaging to assess for complications in a patient who's listening?
Yeah, so as I mentioned in my talk, I don't typically resort to it. Often it gets done in the emergency room because those are the decision makers in the emergency room. So oftentimes it's done. And but if I were sitting in the emergency room, I wouldn't necessarily get it unless you have a patient who's not a reliable historian. You have a patient whose history goes for several days and the labs don't support acute pancreatitis, but you still suspect it. Or if the pain is just out of proportion, then you might think there's something else going on, like a perforated discus. In those situations, I would get imaging. Otherwise, I typically wait for about day 5 to 7. If a patient is still hospitalized and not recovering as I would expect someone to with a mild or interstitial case of pancreatitis, then I would start to suspect that they have moderate to severe pancreatitis and there might be some peripancreatic necrosis. And at that point, I would probably get some imaging.
I think we can take the last question. It's related to COVID. Have you seen many cases of COVID-induced pancreatitis in your practice? If so, have you had any particular observations in terms of severity and pancreatitis-related local complications?
So I've seen the literature, but I haven't personally seen a lot of COVID-induced cases, and it hasn't really affected my practice.
All right. Well, thank you. Thank you, Dr. Park, for that excellent presentation. And we're going to move from the world of acute pancreatitis to chronic pancreatitis. Our next talk is on the evaluation, genetic testing, and management of chronic pancreatitis. Dr. Anna Evans-Phillips is joining us from the University of Pittsburgh Medical Center, where she's an assistant professor of medicine in the Division of Gastroenterology and is a clinical researcher in the area of medical management of chronic pancreatitis, and particularly has some very innovative research in assessing pain and neuropathic versus visceral pain in chronic pancreatitis. So I will hand it over to you.
Thank you so much for the very kind introduction, and thank you, Dr. Park, and everyone else, Dr. Park, for the great presentation on acute pancreatitis. What a huge topic, and to everyone for your attention and for taking a little bit of time this evening to be with us. And so, as Dr. Bellin had mentioned, tonight I'll be talking in the area of chronic pancreatitis. Of course, please, again, put any questions that you have into the chat, and I'll be happy to try and address at the end. This is also a pretty big topic, and so I'll cover things in a big overview sort of fashion, but I'm happy to discuss specifics as needed. And so first we'll talk about diagnosis of chronic pancreatitis, then epidemiology of the disease, some clinical and imaging features that are consistent with the diagnosis, testing both for chronic pancreatitis as well as in relation to sequelae of the disorder, some associated complications that are frequently seen, and some additional ideas about management. So the first and most important thing to consider carefully is what definition we are using for chronic pancreatitis. There is no universally accepted definition of chronic pancreatitis, and so it's a very important fact that kind of underlies the study and discussion of this disorder. But broadly speaking, it's a fibroinflammatory disease of the pancreas that is the result of inflammation that does not heal or improve. It results in permanent damage and often scarring to the pancreas, which can result in chronic pain, as well as the inability of the pancreas to make digestive enzymes or hormones. It's a relatively rare disease, and so we see an incidence of somewhere between 5 and 12 per 100,000 persons in the US, then with a prevalence of about 50 per 100,000 persons in the US. It affects men more than women, and it affects people within a middle age range between 40 and 60 most frequently, but there are certainly patients in whom the incidence is seen both before and after that age range. It affects African Americans disproportionately to Caucasian Americans, with a 2 to 3-fold relative increase in that population for reasons that aren't altogether well understood. This schematic here from my colleague and great mentor, Dr. David Whitcomb from Pancreatology in 2016, shows one of the most common kind of conceptual models that we use to understand chronic pancreatitis. Now, there are ways that this has been updated, and we understand more about incidence of chronic pancreatitis now than even 6 years ago. But this very nicely lays out the idea that many patients experience acute pancreatitis, as just described by Dr. Park, and then can move into a recurrent cycle of acute pancreatitis or recurrent acute pancreatitis, and develop a gradually scarred pancreas, which then moves to the right along this continuum and ends up with end-stage chronic pancreatitis with a number of sequelae and complications that can be very difficult to treat. And so clinical features of the disease, as I mentioned, there's no universally accepted definition, and there is no simple, reliable test to definitively diagnose chronic pancreatitis. But a typical presentation for many patients might include abdominal pain, which is either chronic or postprandial or episodic in some other fashion. Many have had a prior history of acute pancreatitis. Some may present with evidence of weight loss and a fatty diarrhea that's called steatorrhea. Some may also present with concomitant diabetes from destruction of beta islet cells in their pancreas, resulting in concomitant diabetes with that disorder. Now, the kind of gold standard for chronic pancreatitis would be histology. In other words, a sample of the pancreas that comes directly from the organ itself, which could be compared to other samples. However, this is, as you can imagine, very difficult to obtain, mainly because we don't frequently biopsy the pancreas. That can certainly result in acute pancreatitis, and so this is avoided unless it's absolutely necessary or there's an appropriate clinical situation in which to do so. But what you would see if a biopsy were obtained would usually, in the setting of chronic pancreatitis, be patchy fibrosis that distorts the ducts and often replaces the acinar cells, which are the functional unit of the pancreatic parenchyma. And so our most frequent diagnostic tool that is commonly used in the inpatient and outpatient settings would be a CT of the abdomen and pelvis. And so this shows two examples of axial cuts of CT scans showing on the left evidence of a relatively healthy looking pancreas outlined in green there, where you see, a kind of homogeneous gray organ that has a good amount of body to it. And then on the right, it's not outlined, but in the same position there, you actually see an atrophied pancreas with white splotches throughout it that actually represent calcium deposits, both in the parenchyma of the gland as well as in the main central duct of the gland, that are going to block or obstruct flow of pancreatic juices out into the duodenum. Now, just for comparison's sake, because many of us see imaging modalities of many different kinds, an MRCP image on the top shows essentially your biliary tree with your gallbladder and then common bile duct coming down, and then the pancreatic duct in kind of a serpine fashion off to the right. And this is a relatively normal looking MRCP. In the bottom two images on the left, what you see are evidence of pancreatic duct strictures. The letter A and the two right hand arrows are pointing to those, and then the letter B is pointing to an area where there actually looks to be a leak from the pancreatic duct and likely a pseudocyst adjacent to it. On the right hand side, you see actually a dilated pancreatic duct with evidence of filling defects consistent with stones. On endoscopic ultrasound, for what it may be worth, especially for those who may be interested in this imaging modality, you might see findings consistent with calcifications, dilated pancreatic duct stones, or lobularity in the pancreatic parenchyma. Now, regarding etiologies or reasons for pancreatitis, there are many different ways to think about the factors that can lead to chronic pancreatitis. One of the main ones that is used is actually called the TIGAR-O risk factor classification, which I'll demonstrate here just for the sake of trying to be thorough about describing the overall etiologies. And so these might consist of things like toxic metabolic causes, alcohol, which is one of the most common etiologies of chronic pancreatitis, tobacco, which we now know after a couple of decades of careful research on this, which is also very toxic to the pancreas and can cause progression of disease, hypertriglyceridemia or hypercalcemia. Then next, the idiopathic category includes all the things that we don't yet know about, which cause chronic pancreatitis. Under this is the genetic etiologies, and here I've just included 4 of the most well-known, including hereditary pancreatitis, which describes the PRSS1 gene mutations, cystic fibrosis, SPINK1, and then CTRC. Autoimmune or immunologic etiologies of chronic pancreatitis. And then patients who have recurrent acute pancreatitis can develop damage over time, as I showed with the schematic earlier. And then obstructive chronic pancreatitis, including things that might cause damage to the pancreatic duct or recurrent gallstones, or perhaps even congenital abnormalities, which result in obstruction to the pancreatic duct. Now, on to some discussion about management, actually. When a patient comes into the office for evaluation and management of potentially a new diagnosis of chronic pancreatitis, there are 2 main categories that I think of in terms of what I'm going to do for them. One is to evaluate for etiologies. Why do they have chronic pancreatitis? A careful clinical history is, of course, the most important thing that you can do, but there might be some additional testing that I would send. So this would include things like consideration, at least, of possible genetic testing, and I'll get into that in just a moment, triglyceride levels and calcium levels, liver function tests, things like celiac disease panel, because that can result in recurrent acute pancreatitis over time, eventual chronic pancreatitis in the end. If there is concern for underlying autoimmune etiology, things like total immunoglobulin levels and an IgG4 may be instructive on that level. Then, even if I'm not able to land on a specific etiology of chronic pancreatitis for them, I may be very concerned about what complications or sequelae of the disease that they have. So I'm going to consider testing for their fecal elastase level to look for the degree of pancreatic enzyme that is excreted in stool to see whether that is normal or whether they have evidence of exocrine pancreatic insufficiency, which I'll talk about a little bit more later. The hemoglobin A1C level to look for evidence of diabetes. fat-soluble vitamin levels, including things like vitamins A, D, E, and even a PTINR as a proxy, perhaps, for vitamin K. Then liver function tests to evaluate for things like strictures in the biliary tree. And then a DEXA scan, a bone density scan, essentially, which can give us some sense of whether patients may have developed mineral bone disease as a sequelae of malabsorption. And so, on the note of genetic testing, because it was part of the title of the presentation, I certainly wanted to make mention of this because it's an important and emerging part of chronic pancreatitis research that is a very exciting one and offers some potential therapies for subpopulations within this group. And so this is actually taken from an advertisement for aerial precision medicine via Chirocline. And I have no disclosures, but I mention this just as one of the most thorough opportunities that's available for testing on the market. Now, I will say that many hospital systems offer genetic testing for the most common genetic etiologies of chronic pancreatitis. And so looking into other options is perfectly great. But what I'll highlight here is just that there are at least a dozen genes that have been described in the literature and some are more well known than others, and their effects on the pancreas, the effects of the gene mutations downstream on the pancreas have been described in varying detail, but all of these are available in a commercial fashion for testing to be able to help inform the situation of the patient who may be sitting in your office. And so I'll just talk briefly about three of the most common gene mutations or kind of genes that have multiple potential mutations that can contribute. And so the cystic fibrosis transmembrane conductance regulator, or CFTR, one of the most common mutations that we might test for related to chronic pancreatitis. What you see over on the right is actually another axial scan of a pancreas that has fatty replacement. And this patient had a cystic fibrosis mutation that resulted in this phenomenon. What I will say, though, is that the actual phenotype that you see, the presentation of these patients is quite variable clinically. But cystic fibrosis as a syndrome is an autosomal recessive disorder, and typical chronic or cystic fibrosis includes pancreatic agenesis or atrophy at a very young age for most of these patients. They often have abnormal sweat chloride or nasal bioelectric response testing. They may have respiratory inflammation due to recurrent or chronic infections. Sometimes there may be manifestations like male infertility in the well-described syndrome of cystic fibrosis. What we learned, though, through, again, a series of very carefully researched questions is that actually what I'll call here as an atypical cystic fibrosis may manifest actually as pancreatitis alone. What we know is that there are numerous mutations in the cystic fibrosis gene, which can result in alterations in not only things like the sweat chloride test, but also alterations in bicarbonate secretion in the pancreas. And so we've seen that there can be a high frequency of cystic fibrosis mutations that have been discovered in idiopathic chronic pancreatitis, and even some in patients who were previously determined to have alcoholic chronic pancreatitis. And so what I would say is that cystic fibrosis variants can play a major role in idiopathic chronic pancreatitis, even without a classically described cystic fibrosis syndrome. This can also be of interest when it's linked to things like SPINK1 mutations, another gene that is well described, which can modify the presentation. SPINK1 is the acronym actually for the serum protease inhibitor, and this is an important loss of function mutation, which is relatively dose related for patients, where patients who are homozygous for mutations have usually a more pronounced abnormality in their phenotype than those who are heterozygous. This is a mutation that is relatively common overall, where it's present in about 1% of the world's population. And so patients who are, or rather individuals who are unaffected, who don't have pancreatitis, this may have no significance in their overall health. But in a patient with recurrent acute pancreatitis, the presence of a mutation in this gene may actually suggest that they could have a worse disease course than someone without this, and suggest that they're at higher risk for progression in their chronic pancreatitis. So then just briefly, in the interest of time, hereditary pancreatitis describes mutations actually in the PRSS1 gene. There are 4 that are particularly well described, and these are gain of function mutations that increase the activation of trypsinogen and decrease its inactivation. This is an autosomal dominant disorder, and about 80% of those who have one of the gene mutations show signs of acute pancreatitis. And in 50% of those, they may go on to develop chronic pancreatitis. There's also been an increased risk of pancreatic cancer described. The actual numeric increase in risk is of some controversy, but note that it has appeared to be present and increased in those relative, those with hereditary pancreatitis more so than those with other causes of chronic pancreatitis. So why is genetic testing relevant? Is there anything that you can do about it? One of the things that I just want to raise, which is a very exciting area of research and offers some potential hope, especially for patients with chronic pancreatitis, or rather recurrent acute pancreatitis not progressed to chronic pancreatitis, is the area of cystic fibrosis modulator therapy. And so I raise this because sometimes patients who come in with recurrent acute pancreatitis are looking for ways to prevent their progression. And in certain patients, there may be the opportunity to use these medications if they have a mutation that may be appropriately treated with one of these medications. And so I've highlighted here just a single article actually from some of our colleagues at Johns Hopkins showing that cystic fibrosis transmembrane conductance regulator modulators have been shown to reduce the risk of recurrent acute pancreatitis in a specific group. And so with that, kind of returning to more of the mainstream things about chronic pancreatitis, I'll say with regard to the natural history of the disease and talking about recurrence, Dr. Park mentioned how prevalent actually acute pancreatitis is in the population, and that this is a very common diagnosis. Approximately 20% of those patients who have acute pancreatitis will have a recurrent attack. And although 4% doesn't sound like a lot, when you think about how common acute pancreatitis is, 4% of all patients with acute pancreatitis going on to develop chronic pancreatitis actually seems like a big number. And so in patients with alcoholic acute pancreatitis, rates are actually higher, and in some places have been estimated, to range very high, from 13 to 90%, which is quite a wide estimate. But we do know that continued alcohol use and continued tobacco use are well described to hasten progression of the disease from acute through recurrent acute to chronic pancreatitis. And so I'll mention just briefly interventions because they are part of the overall picture, but you'll have other discussions about this, I think, in coming weeks. And so in tertiary referral centers, approximately 40 to 67% of patients with chronic pancreatitis will undergo invasive intervention for therapy of their disease. This includes about 60% who undergo some type of endoscopy and 30% for some kind of surgery. In community hospitals, these numbers are lower, about 30% overall, with 23% undergoing endotherapy and maybe 11% having surgery. But I wanted to give you those numbers because the point is that many patients never undergo any kind of invasive intervention, and therapy is specifically limited to medical management. And so one of the most important things that we deal with in this patient population is pain, which very specifically does not correlate with imaging findings. So in other words, you can have a patient who comes in with very impressive calcifications in the pancreas, evidence of dilation of the duct and atrophy, and this does not correlate with their everyday experience. They may be walking around, working, taking care of a family, and have no pain, whereas someone with very mild changes in the pancreas may actually have very severe, debilitating pain. There has been a prior well-used description of types of pain in chronic pancreatitis where patients may have type A sort of pain, where they have long periods of pain-free intervals for several months or years, as well as type B pain, where patients have an underlying chronic pain with exacerbations of pain, perhaps related to triggers of recurrent attacks of acute pancreatitis or for other reasons. About 20% of patients with chronic pancreatitis have no pain, and in some patients, importantly, who undergo surgical treatment for painful chronic pancreatitis, a high number, even maybe greater than 50%, end up having pain recurrence. There's a theory about a decrease in pain over time, with patients having sort of a burnout of that experience. However, that hasn't really been shown to be borne out in more recent evidence. More frequently, actually, we see escalation of medical pain treatment in a fashion that's consistent with the World Health Organization's pain treatment ladder. And so most frequently we see patients in the US actually start out with non-opioid analgesics, moving through strengths of opioids, and eventually, having to move to intervention if medical management is inadequate. And so in the interest of time, I'm just going to move quickly actually through alcoholic chronic pancreatitis as the most common cause of chronic pancreatitis, but is mainly associated with often very heavy alcohol consumption. And that has been enumerated in the past by, again, kind of very careful looks at epidemiologic studies related to chronic pancreatitis. Tobacco, very importantly, is an independent and dose-dependent risk factor for chronic pancreatitis, and the effects of smoking are stronger in alcohol-related chronic pancreatitis. And I raise this because one of the main things that you can do for patients with chronic pancreatitis to slow the progression of their disease is have patients stop smoking. Pancreatic exocrine dysfunction, or exocrine pancreatic insufficiency, as you may have heard it called, is the situation where patients are not producing enough digestive enzymes from the pancreas. It has a large secretory capacity, and oftentimes we see this in very late stage chronic pancreatitis, but we're starting to understand that this can actually occur in more subtle fashion earlier on in the course of disease. The treatment for exocrine pancreatic insufficiency is supplementation with pancreatic enzyme replacement therapy. Now, pancreatic endocrine dysfunction is diabetes, and this is commonly known as type 3C diabetes, which we know has a very wide range in estimated prevalence, but we see increased risk with increased duration of disease. And I will say that there is a lot of ongoing research currently with specific interest in trying to understand more about this. I mentioned already the increased risk of pancreatic cancer in this patient population, which is an important potential complication for this disease. There is a decreased quality of life that is seen in these patients overall, and importantly, there is a higher mortality in this patient population as compared to the general population. Now, interventions to alter the course of the disease, as I mentioned, include things like alcohol abstinence, abstinence from tobacco, medical therapy, including therapy for pain, as well as pancreatic enzyme replacement therapy. Endotherapy and surgical therapy are often reserved for very specific patients in whom there is thought to be potential benefit. And so with that, I'll end in the interest of time and just say thank you so much for your attention and for the opportunity to talk with you tonight, and be happy to take any questions.
Thank you, Dr. Evans-Phillips, for that wonderful presentation. We do have some questions in the chat. So can you discuss autoimmune pancreatitis as a cause of irreversible damage to the pancreas? Is the pattern of damage different from other forms of chronic pancreatitis?
So what I can say about autoimmune pancreatitis is that it's a very rare disorder, actually. And so I'll start by saying that, just because it's a very important underlying message. It is well described, and there is a kind of a set of therapies that we use to treat autoimmune pancreatitis. I would say that the natural history of the disease does end up often being different than other forms of chronic pancreatitis, other etiologies that might cause a more typical chronic pancreatitis. And so I would regard it in some ways actually as a separate disorder that has a separate set of treatments than what we would usually use for a more typical form of chronic pancreatitis.
Great. Thank you. The next question here, actually, part of it asks if you could put back up the slide that has the workup, which was earlier in your slide set. I don't know if you're able to flip back to that, but
sure.
if you can, we could certainly have that up while you're answering the other questions.
Sure. Oh boy.
People were interested in seeing that. Yeah. You could, yes, just go to slideshow mode. I like that.
Sure. Here we go. I think I called it
There we
the
go.
in-office testing.
So, and while that's up, there's also a question here
Sure.
then about what longer term treatment is there for idiopathic or genetic pancreatitis?
That's a great question. And I think that's the thing that we all have to ask ourselves when a patient with chronic pancreatitis comes into the office. As Dr. Park mentioned, for acute pancreatitis, unfortunately, we don't have any drug therapy for the treatment to either reverse or slow the progression of disease, except for in very rare cases. As I mentioned, in certain patients with recurrent acute pancreatitis in the setting of a very specific cystic fibrosis gene, in some ways those patients are lucky because of the opportunity that has been afforded them with this kind of medication. What a dream, for patients who have a recurrent acute pancreatitis or who have developed chronic pancreatitis where the disease is irreversible. And so what I would say in this situation is that the most important thing is to assess where you are in the disease process at the current time with the patient and come to an understanding not only of that, but of what things you can make an impact on. Are there ways that you can treat pain for them? Are there ways that you can treat other complications that they have? And are there ways that you can prevent future complications for them through surveillance or additional testing?
I think that actually the follow-up, the next question in here was very closely related, asking specifically about pharmacologic therapy for non-CFTR genetic chronic pancreatitis, but this question asked about a couple specific agents, ursodiol, amitiza, whether they might have any role, I guess, in symptomatology around this.
Those are great questions, and I would say that there's not extensive evidence basis for additional agents at this point in time. I would say that, there are a lot of things that we have interest in, and there are also many off-label uses that we see, not infrequently. But at the moment, right now, I can't say that there's a lot of evidence for additional agents like that.
We have two more questions, I think, Anna. The next one is related to incidental cross-sectional imaging findings that suggest chronic pancreatitis, such as calcifications, fibrosis, or delayed PD. And the question is, are these imaging findings enough to diagnose chronic pancreatitis, or do we need at least some form of relevant clinical manifestations, such as exocrine pancreatic insufficiency or pain episodes?
What an excellent question. Again, I think that these are, this is the basis for a lot of patients that we might see in the office. These are surprising findings seen incidentally. And so someone wants to know, how important are they and what do we do about them? This gets back to actually the fact that there's not a universally accepted definition of chronic pancreatitis, nor is there one set of diagnostic criteria. And so I'd refer back actually to, different diagnostic criteria that might help you to classify those imaging findings in a relevant way. In other words, you could use things like the Cambridge criteria for imaging findings consistent with chronic pancreatitis. You could also use the Mannheim criteria, which actually use a lot more, clinical measurements in order to determine the, kind of grade and severity of the relevant findings. I think there are two questions that are posed within this, and the first is, do you diagnose them with chronic pancreatitis? And I think that you can make a decision on based on which criteria you're using. And the second question is, what do you do about it, if anything at all? And so I think there it's important to assess what the degree is of dysfunction or malfunction of the organ and what effect it may be having, and then decide from there actually how to go about determining and initiating therapy.
The final question in here is about enzyme therapy and enteric-coated versus non-enteric-coated, specifically for the use of pain control. It says I was a non-enteric prescriber when they were taken off the market for a while in the early 2000s, and my patients complained of increased pain in 70%, and also notes that they must be taken appropriately.
Thank you for that comment. I think that raises, a lot of issues around pancreatic enzyme replacement therapy, and kind of a appropriate prescription and so forth, and how individual the experience can be actually of receiving those medications. They are very important and they are very useful in the right clinical setting, and so it's really important to have a careful conversation with the prescriber of those about their efficacy and how they may be helping. So thank you.
All right, well, thank you. That brings us right to the hour. So perfect timing. Thank you, Dr. Park. Thank you, Dr. Evans-Phillips. That was a wonderful session, and thank you everyone for attending tonight. And I'm sure if you have follow-up questions, you can reach out through the organizers of CAPER to communicate any questions back to the speakers tonight. All right, thank you.
Thank you.
Take care. Have a good night.
Thank you all. Good night.